This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hello and welcome. This is Justin Abbatemarco from the Neurology podcast team, and I'm joined by Dan Ontaneda to discuss this latest paper, Diagnosis of Multiple Sclerosis, 2024 revision of the McDonald Criteria, published in Lancet Neurology. Dan is a staff physician at Cleveland Clinic Mellon Center and was involved in this update. So we're really excited to welcome him on the podcast where we can dive into some of these changes and maybe take an opportunity to peek around the corner on how some of these recommendations were made in the committee meetings. Dan, hello and welcome.
Thanks so much, Justin, for having me.
Maybe we could talk about a few major themes that are really going to impact people when they're in the clinic seeing patients. What do you think the top 2 to 3 takeaways are?
I think they surround, I would say, 3 major themes. One is we want to make a diagnosis early and accurately. And so making sure that the diagnostic criteria continue to be sensitive, that is, we're able to detect people who have MS at the earliest stage of the disease. Second, increasing specificity for the diagnosis, that is, making sure that we're not incorrectly diagnosing. And then the third one is that we are taking a very clear departure from making the diagnosis of MS just fully based on clinical presentation. And this perhaps, I think, is the largest philosophical change in the diagnostic criteria. And one of the things that you'll hear about the most when people talk about the new diagnostic criteria is that now we can make a diagnosis of multiple sclerosis in people who are asymptomatic, that is, they only have incidental findings of demyelination, and also in individuals who have symptoms that are considered not specific for multiple sclerosis. This is important because it's the first time that we can make a diagnosis of MS in those individuals. And so it really opens up the umbrella on who can be diagnosed with MS. And this is an evolution. There's been a lot of data that has been produced suggesting that these individuals, when we have biological evidence of the disease, that they indeed do have multiple sclerosis. So to see that actually appear in the criteria is really important. And hand in hand with that, what these criteria do more than any criteria in the past is that the reliance on clinical symptoms is less, and there's a greater reliance, and there's a greater role for very specific biomarkers of the disease. And some of these we've worked on, including the central vein, paramagnetic rim lesion, but also, of course, cerebrospinal fluid that we've been using now for many years to make the diagnosis of MS.
I completely agree. When we look at this, it feels like a really seismic shift here in this latest criteria, and that background is helpful. The move to a biological diagnosis, that's the analogy you guys used in the paper, and then talked about how the neurodegenerative world, with their development of these incredible biomarkers, is also moving in that phase. And so maybe MS is following that roadmap. Does that sound fair?
Yeah, that's absolutely correct. I think we realize that the field of neurology has to move away just from clinical characterizations alone to think about the pathological processes that bring neurological disease to bear. And the reality is that in a lot of neurological diseases, what we call the pre-symptomatic phase might be quite long. That's true, of course, for conditions like Alzheimer's or Parkinson's disease that have had really well-known, established, at least in Parkinson's disease, prodromal phase. But we're finding that in multiple sclerosis, it's quite similar. So if you look at an individual who's diagnosed with MS, you look at that first MRI, and it's clear that those lesions probably have been accumulating for years. There is a proportion of individuals who have no clinical symptoms but have MRI features of the disease. And then finally, if you look at individuals prior to their diagnosis, you can actually find that they're, one, consuming the medical health system more than people who don't go on to develop MS. And second, importantly, when you look at them, actually, if you look at their blood work, they will have elevation of stuff like neurofilament light levels. And so this indicates that biologically the disease is changing before we have clinical manifestations. One of the analogies that I like to make when I talk about this is an example from cardiology. So, when you are diagnosing a patient with mitral regurgitation, you typically do an echocardiogram, you find it, and the diagnosis is made. Rarely do we wait for people to have the end stage of valvular heart disease before we make these diagnoses. The diagnosis is purely an echographic diagnosis. And similarly in MS, we have to recognize that when an individual has lesions in the brain that look like MS, lesions in the spinal cord that look like MS, when their cerebrospinal fluid is positive, when they have lesions that show gadolinium enhancement. And when they have specific imaging biomarkers, including the central vein sign and the paramagnetic REM lesion, that person biologically has multiple sclerosis. It's just that you've caught them before they've had clinical manifestations, and treating them as such, it makes sense. One of the things that we've talked about with making biological diagnoses is that you really have to put some work into developing the measures that you use. And we've incorporated these measures based on a lot of data, which will be reassuring to hear for clinicians.
Maybe we could dive into some of the major changes, and maybe one of the headlines is this inclusion of the optic nerves. How should we be thinking about that as we're trying to make the diagnosis of MS in the clinic? How do we evaluate for that etiology, and how will we incorporate it into our diagnostic algorithm?
Yeah, so the inclusion of the optic nerve is something that was discussed already in the 2017 revision meeting. And it was felt that there wasn't sufficient evidence. And so as a field, investigators have been investigating the role of the optic nerve in the diagnosis of MS, actually did a lot of work to produce the data that actually have led to the incorporation of the optic nerve into the diagnostic criteria. And so you might remember that typically in multiple sclerosis, we base the diagnosis based on a concept that we call dissemination in space, and then dissemination in time. And dissemination in space is that you have to have lesions that span different areas of the central nervous system. And that can be done based on the neurological examination. It can be done also based on the patient's history, of course. It has to be confirmed on the neurological examination. But we can also do it based on MRI. And in order to have dissemination in space on MRI, what the 2017 criteria used was that you had to have one or more lesion in two or more of four typical locations. And these are typical places where we see multiple sclerosis lesions: periventricular, juxtacortical or cortical lesions, infratentorial lesions, and spinal cord lesions. Now, the optic nerve was not one of these four topographical regions or anatomical locations that we could use to make a diagnosis and use to satisfy criteria for dissemination in space. But we know that optic nerve involvement is quite common in multiple sclerosis. About a third of cases of clinically isolated syndrome, the first attack of MS, affect the optic nerve. And you could use the optic nerve when it was present clinically to demonstrate dissemination in space and dissemination in time previously. But what we couldn't do was to find abnormalities on MRI or on paraclinical testing that documented optic nerve involvement, sometimes subclinically, to meet criteria for MS. And the inclusion of the optic nerve as a new fifth anatomical region essentially allows us to be more sensitive to make the diagnosis of MS without costing us specific specificity. And that's an advantage because it will increase the number of people we can diagnose with MS without incorrect diagnoses. And this can be done in a variety of different ways. And for clinicians, it will be easy. They will use the tools that many times they probably are already familiar with. So specifically on MRI, if you find a unilateral short segment lesion in the optic nerve, and that can be just on a regular MRI of the brain or on a dedicated MRI of the orbits, satisfies the criteria for that anatomical location in the optic nerve. You can also use optical coherence tomography. Ophthalmologists have been using optical coherence tomography for years, but now it's quite commonplace in neurologists' office. And it's a test that's relatively easy to do. And if you find specific loss of the peripapillary retinal nerve fiber layer or the ganglion cell interplexiform layer at very specific thresholds, that when found, comparing one side to the other, can be demonstration of unilateral optic nerve involvement. And then finally, a test that has basically come back to the diagnostic criteria, which is visual evoked potentials. And visual evoked potentials is a test that had been used extensively in the diagnosis of MS, especially prior to the availability of MRI, and can still be used to document if there's an increased latency in the P100 waveform, especially when comparing between eyes. That can be used to document that there is unilateral optic nerve involvement. So the optic nerve is affected commonly in MS. We can image it using MRI, we can image it using OCT, and we can also interrogate it using a sensitive functional test such as visual evoked potentials, and it can help us to meet criteria for dissemination in space. If you have one or more lesion in two or more topographies out of the five instead of out of the four, you can actually satisfy criteria for dissemination in space, which of course makes the diagnosis easier.
That discussion initially around like clinical versus subclinical disease is really helpful because this is confusing, right? People have known, and we talk about optic nerve pathology from the very beginning when we've talked about MS. And this idea that we now can visualize the optic nerve with the tools you already mentioned, MRI, OCT, VEPs, to really look for subclinical disease activity, which we can now incorporate into that algorithm, is really helpful. And again, really increasing sensitivity, making the diagnosis early without sacrificing or making incorrect diagnoses. It's a huge change. And we're going to spend a lot of time, and we'll link some episodes on how these tools like MRI, OCT, VEPs, how we can incorporate them into the clinic on the podcast and Neurology Minute. So stay tuned. Maybe one of the most exciting pieces from my perspective is this incorporation of those advanced MRI tools, which you mentioned in the introduction, the central vein sign, paramagnetic rim lesions. I don't think we need to mention on the podcast because we've all experienced, you open an MRI up, there's this subcortical white matter disease, and we do a lot of hemming and hawing. Is this something that's concerning for MS? Should we do more evaluation? These tools are really going to give us something to be more scientific about it. Could you talk about those two signs and how we're going to think about those in clinical practice?
We've struggled a lot with applying our MRI criteria outside the specific clinical context of a clinically isolated syndrome. And an example that I like to make is if you take a 50-year-old who has vascular risk factors and has small vessel ischemic disease, it is very likely that you are going to be able to find at least one lesion that touches the cortex, at least one lesion that touches the ventricle. You'll probably find a lot of infratentorial lesions, right? And so one of the problems with application of MRI criteria is that if you don't apply them in the context where they were intended to be used, and also if you're not careful with what exactly those lesions look like, many times you can incorrectly diagnose a person with MS. Now, these specific imaging markers that we're going to talk about, both the central vein sign and the paramagnetic rim lesion, the reason they were incorporated into the diagnostic criteria is because they're very specific for MS. A white matter lesion that has a central vein essentially is the imaging demonstration of what we call perivenular demyelination, which always happens in the context of an inflammatory demyelinating disease like multiple sclerosis. And so finding the presence of a very small vein in the middle of these lesions actually assures you that the lesion you're looking at is an MS lesion. And how can you view these veins? We know the veins have existed. Even from back in the 1800s, there was already pathological descriptions of multiple sclerosis lesions with central veins in them. But it was only until recently that we've actually perfected the technology on MRI to sensitively image veins in the middle of lesions. And that can be done on sequences that we call susceptibility-based sequences. Typical examples of this include susceptibility-weighted imaging and T2 star imaging. And on those images, if you look at MS lesions, you'll find that in the middle of the lesion, there's a thin dot or hyperintense line that basically is the vein around which that lesion has developed. And we've allowed this to be incorporated into the diagnostic criteria using a simple rule. And that rule is that if you have an MRI that has 6 or more of these central vein lesions, you basically have a test that is indicating a higher likelihood of multiple sclerosis. Now, if there is fewer than 10 lesions, all we ask is that the majority of the lesions have a central vein, because we thought there might be people who are diagnosed really early on when they have fewer than even 6 lesions. And so for those folks that have less than 10 lesions, we say a majority have to have the central vein. So that's quite easy to apply in clinical practice. You have to count up to 6 lesions. In the case that a person has only 10 lesions, you just have to make sure that the majority of lesions have a central vein. And I think that if you use the right sequences, an SWI sequence or a T2 star sequence, that should be quite easy to do. I would like to shout out that in addition to the paper that you mentioned on the diagnostic criteria, we are also publishing a concomitant paper in Lancet Neurology that covers the MRI features in the diagnostic criteria. And we have very specific recommendations on what sequences can be used to detect the central vein. And so I would recommend that people look out to that article, share that with your local neuroradiologist, and ask them to implement them. All those sequences, the vast majority of those sequences, can be implemented on your clinical scanners. So CVS, actually, the central vein sign, is a test that shows reasonable diagnostic sensitivity and really high specificity across multiple studies and in meta-analysis. And then the second very specific imaging biomarker is paramagnetic rim lesions. And interestingly, paramagnetic rim lesions use the same sequence, a post-processing method of that sequence called phase imaging, which allows us to identify the presence of iron around the periphery of a lesion. And that iron turns out to be in microglia cells, macrophages, around the lesion border in a subset of lesions that we've termed chronic active lesions. And the presence of these chronic active lesions can be viewed on those same sequences and basically appears as a hypointense rim of iron around the periphery of the lesion. And if you find one or more of those lesions, that is a highly specific finding for MS. It turns out that there's very few other conditions that have the presence of these paramagnetic rim lesions. It's virtually, when you see it, you can be pretty sure that's multiple sclerosis. And so both these biomarkers are going to help clinicians when they open up an MRI. If you see that you have one of these sequences, it's very clear. If you see the vast majority of lesions have a central vein, this is likely MS. Or if you see on top of central vein lesions, you also see one of those rim lesions around the lesion that looks like iron, you can be pretty sure that's MS. Now, in the diagnostic criteria, CVS currently have a slightly greater role because there's been more data produced for CVS, but we expect PRLs actually to probably make it to the same level as CVS in future editions of the diagnostic criteria. And CVS is important because in the past, if you had a patient who met dissemination in space, like we talked about when we talked about the optic nerve, you need a confirmatory test to make a diagnosis of MS. And just having the presence of these 6 central vein lesions enables you to diagnose MS. So you don't have to wait for DIT, and you also don't have to wait for the presence of oligoclonal bands on CSF. So you're saving the patient a spinal tap, and you're potentially saving the patient any time that they need to wait before you can actually confirm a diagnosis of MS.
You have so much stuff in that answer. I just wanted to maybe think about it with you again. So we have these 2 tools really adding to that specificity of this diagnosis, really making sure that we're accurate. That example you gave at the top, these older patients with lots of white matter disease, now we can put some additional tools in our toolbox to understand. And one of them is central vein sign. And we're going to hear a lot about the Select 6 score, which you described, trying to find at least 6 lesions with a central vein sign is enough. And then this paramagnetic rim lesion, another very specific sign for MS that can help us triage these cases. And all of these tests can be done on routine MRIs. There's a little change in the background, and we'll link those articles that you already mentioned on MRI and the visual parameters in these episodes. But does that sound like a good summary of these tools and how we're going to use them in clinical practice?
So these are 2 tests that can be used to confirm the diagnosis of MS. And the central vein sign specifically is used in people who have a typical clinical attack or progression. If they have DIS, the presence of Select 6 CVS, which is those 6 central vein sign lesions, confirms a diagnosis of MS. For paramagnetic rim lesions, where we use it in the diagnostic criteria are for people who just have one anatomical location. If they have both the presence of positive CSF and a paramagnetic rim lesion, or dissemination in time on MRI and a paramagnetic rim lesion, you can make a diagnosis of MS. So helpful both for people with 2 topographical lesions and people with 1 topographical lesion.
And throughout this episode, we've talked a lot about dissemination in time and space. It's our personal mantra in multiple sclerosis. And we've had some shifts here. We're going to have to think about how we mention this when we talk to our trainees. But can you talk about how the changes around dissemination and time have evolved? We've seen that maybe change a little bit in 2017 criteria, but some pretty significant changes here in 2024 as well.
Yeah, that's right. We've tried to move away from the need for dissemination in time. And that, like you said, was already present in the 2017 criteria. Historically, to be diagnosed with MS, you always needed both dissemination in space and dissemination in time. And in the 2017 criteria, we made the first move away from requiring the need for dissemination in time. And we said that if a person has positive cerebrospinal fluid oligoclonal bands, essentially, you didn't need to wait for dissemination in time. That is, you could already make a diagnosis of MS. In the 2024 McDonald Criteria, we take it even further. In those criteria, what we say is that if a person has dissemination in space, you can confirm the diagnosis of MS based on the presence of positive cerebrospinal fluid, which is oligoclonal bands, or the new CSF marker, kappa-free light chains, which we haven't talked about yet, or by the presence of Select 6 CVS. And then finally, if a single MRI shows both enhancing and non-enhancing lesions, that counts as dissemination in time. So the concept here is that you can use specific biomarker tests to replace for the need for dissemination in time so that you can make the diagnosis earlier. Now, additional data also demonstrated that if you have a very large number of lesions across a very large number of topographical locations, the likelihood that you would have a second attack is super high. And so philosophically, I don't think it makes sense to wait or to require additional information to make a diagnosis of MS in those cases. So now, if you have a typical clinical event or a progression from onset as your clinical presentation of MS, if you have 4 or 5 anatomical locations or topographical regions affected, essentially you can make a diagnosis of multiple sclerosis.
And maybe that leads us perfectly into maybe our final question around progressive MS. We've had tremendous progress in this kind of phenotype over the last few years. And maybe I'll shout out G1O's podcast that we did on April 23rd, 2025, where we discussed the BTKIs in this space. But how does this latest criteria help us in this realm? Do these criteria that we just discussed, does it apply to this progressive MS cohort? Are there things that are unique here that we need to think about?
One of the things that we've realized as a field is that multiple sclerosis is a single disease. And the diagnostic criteria previously really separated out how a diagnosis of MS was made in people with relapse onset MS and progressive onset MS. And we've actually removed those differences. And we're now trying to diagnose MS using a single diagnostic framework. And that diagnostic framework will apply to individuals who have relapse onset MS and progressive MS equally. So when you look at the figures, the main diagnostic criteria figures in the paper, what you'll notice is that there's basically a single figure for people who present with relapsing MS and progressive MS. And we thought this was important because we think biologically the diseases are probably quantitatively different, but not qualitatively different. That is, in some patients, we find more inflammation and they tend to have more relapses. In some patients, we find a little more progression and they tend to have a little bit more neurodegeneration. But the reality is that there's a mix in all patients of both these components. And it's important that our diagnostic criteria capture that. And so now the criteria are basically the same for both of these presentations. And the only place where they're different is that there's a very small caveat for people who have progression from many times those individuals may not have as many brain lesions. And therefore, the presence of 2 or more spinal cord lesions in those individuals already counts for dissemination in space. That is, they don't have to meet additional topographical requirements. And this was done specifically because we know that there are people who have progressive onset MS that have a paucity of brain lesions. And so to allow the diagnosis, we decided that it was good to keep that ability to make a diagnosis of MS just based on the presence of spinal cord lesions alone, as long as you had some confirmatory tests such as positive cerebrospinal fluid to make your diagnosis enhancing and non-enhancing lesions. So this unified diagnostic framework really spells out how we think of the disease. We also are working on revised disease course descriptors, and that's work that's ongoing. And we think that goes hand in hand with how we think about the diagnostic criteria. And when we think about unified diagnostic criteria, we think about unifying across presentations, relapsing and progressive, but then also unifying how we make the diagnosis in children, pediatric onset MS, and in adults. And so now these are all combined into a single framework, and that will make it easier for a neurologist. You won't have to look for separate diagnostic frameworks for progressive or relapse onset MS for kids and for adults. You can do it all based using the same framework.
It will make things so much easier. It really harmonizes across these different fields. And then, all of these kind of different subcategories that we've used to chop up MS, they all represent multiple sclerosis. And this kind of really helps us talk about that with our patients. And hopefully will really inform clinical trials as we move forward as well. Maybe this last piece that you mentioned, this positive CSF, we all know about oligoclonal bands, but you mentioned this other term, the kappa-free light chains. Could you briefly talk about what that means and how we can use that tool?
Yeah, so we've used the presence of oligoclonal bands for many years now in our diagnostic criteria. And oligoclonal bands indicate the intrathecal production of antibody. And this is one of the few components of the diagnostic criteria which truly reveals the autoimmune nature of the onset of multiple sclerosis. So of course we thought it was important. Now, oligoclonal bands are somewhat hard to do. They require somebody to sit down and to analyze, either based on gel electrophoresis or isoelectrical focusing, whether the presence of these bands of antibodies are different in a patient's serum versus in their cerebrospinal fluid. And so there is a layer of complexity associated with that. And we know that when antibodies are produced, there's typically an excess of light chain that are produced in relation to the amount of heavy chains. And as a result, these light chains actually are present in excess and can be measured in the cerebrospinal fluid. And so several work across multiple centers, across multiple studies, has made a determination of whether these light chains, specifically kappa-free light chains, can serve as a diagnostic biomarker for MS. And essentially what the study showed, also in meta-analysis, is that the diagnostic performance of kappa-free light chains is nearly equivalent to oligoclonal bands. And so the diagnostic criteria now make these two measures fully interchangeable. And you could say, what's the advantage then? And the advantage comes down to the technical reproducibility of this assay. And so this is something that can be run in an automated way that doesn't require somebody to look at it and can be done probably more cost effectively than traditional oligoclonal bands. This test is already available clinically in Europe and is coming to the United States soon. And it will simplify from a laboratory perspective how you can confirm that presence of intrathecal antibody synthesis. And how you use it, you're going to use it very similar to how you would use another very specific test such as central vein sign. That is, the person who has dissemination in space, as long as they have positive cerebrospinal fluid, either oligoclonal bands or kappa-free light chains, you can make a diagnosis of MS.
From my very brief time in clinical lab, I was shocked at how subjective oligoclonal band testing was when a technician is there trying to look at these gels. It was shocking. And I was telling them like how much weight we put on this. So this is a really important update. And again, another term that is going to really become into the vernacular, these kappa-free light chains, as some equivalent to oligoclonal bands, especially in the MS world. So really helpful. And Dan, such an impossible task to talk about this huge topic in just a few minutes, but we really appreciate your time talking about how we're going to help make the diagnosis earlier in MS more accurately. And then I guess a little bit of a construct in how we think about this disease when we talk to patients, that this kind of biological diagnosis and how that applies. And again, we will continue to explore these different ideas in more detail on the podcast and in Neurology Minute, so stick with us. But Dan, thank you so much for your time and expertise.
It was a pleasure. Thanks for having me on.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to